but it is an option for Medicare patients. But to this point, its use is still very, very limited. The vast majority of stool testing in the U.S. is through tests that look for hidden blood in the stool. And those tests are called fecal occult blood tests, and there are two types. And then within these two subtypes, there are many, many brands. Fecal occult blood tests are either guaiac-based tests or immunochemical tests. And I'll go into some more detail about the differences between the two. Keep in mind, again, stool tests of any type are only appropriate for average risk patients. So whether it's patients with family history or patients with inflammatory bowel disease or past polyps, etc., they are not candidates for stool tests. Colonoscopy is the only appropriate test. Tina?
So the Cologuard test has, on my way up here, I heard it on the, I get that, what's it called, Sirius or Cyrus? I'm not very, but anyways, it was on, so I was listening to CNN, and that came on like 3 times on my wonderful drive up here. That was really boring. And they all talked about it being, cleared by the FDA, but you're saying though it's not on the like U.S. Preventative Task Force, or it's not, docs aren't recommending it, or can you kind of explain that a little bit?
It is mentioned by the U.S. Preventive Services Task Force, but it's not given an A or B recommendation. If it's not given an A or B recommendation, then insurers do not have to cover it. So most insurers, most commercial insurers at this point, have chosen not to cover it. Medicare is the exception. Now, there are a few commercial plans that do cover it, particularly, I think the company's based in Minnesota, and particularly in Minnesota, it's covered by a number of the insurers there. But in general, commercial insurers are not covering it, and therefore, a lot of clinicians aren't recommending it for their patients, or patients aren't choosing to have it because, as I said, Medicare pays $500. I've been told, although this is not, I don't know for sure, but for individuals trying to pay out of pocket, it might be as high as $600 every 3 years. Now, the company has also told me that they will work with uninsured patients, and they will work with federally qualified health centers to try to make it available, but I don't know any details regarding that or how that works. So for right now, its use is pretty limited in the U.S. Now, it is one of those tests that I mentioned the ACS. We're in the process of updating our guidelines. The U.S. Preventive Services Task Force is actually further along in their update than we are. Matter of fact, I've got a slide from their evidence review. And they, in their draft, also include stool DNA and say it's appropriate for some patients, or Cologuard specifically, but they don't give it an A or B recommendation. But that is a draft, and that their final document has not yet been released, so we don't know for sure whether it's going to make the cut.
Thank you.
So, tests that look for hidden blood. Now, and just in talking about these tests that look for hidden blood in general, when we ask primary care clinicians about these tests, one, they don't think they work. There are many clinicians who believe that if they offer stool testing, they're offering second-class testing to their patients. And as a matter of fact, I've had docs in community health centers say, well, no, colonoscopy that's the gold standard, and that's what everyone should get. But unfortunately, even though they recognize that many of their patients don't have access to or aren't willing to have a colonoscopy, that's still the only test they recommend. And in environments where colonoscopy is the only test that's recommended, you usually see significantly lower screening rates. And that's because, in part, the patients have different perceptions, beliefs, and desires than do their clinicians. But one of the issues regarding the second-class level of stool testing, or the persistence of that belief, is that many clinicians still think of stool tests like Hemoccult 2, which they knew had maybe a 20-25% sensitivity rate for cancer. Stool testing has changed over the last decade and changed really significantly. Patient preferences, as I said, are oftentimes significantly different from that of their clinicians. This is a study that was done in a safety net environment, and they had about 1,200 patients, all of whom were due for colorectal screening. They educated everybody about why colorectal screening was important. Then they divided them into 3 groups. One group was told, go get a colonoscopy. Won't cost you anything, just get a colonoscopy. Second group was told, take these kits home, collect stool specimens, bring them back. Third group was told, you can have a colonoscopy, you can do stool testing, you choose. What they found at the end of the study period was 38% of patients who were only offered colonoscopy completed their test. Less than 4 out of 10 people completed their testing with no cost colonoscopy. On the other hand, 2/3 of folks who were only offered stool testing completed. And 2/3 of those who were given a choice between stool testing and colonoscopy completed. And notice, more people chose in that arm chose to have stool testing. So patient preferences are often different than the preferences of their clinicians. A number of other studies have looked at the same issue and found that basically anywhere from 1/3 to half of patients, if given a choice, will choose stool testing over colonoscopy. Up to half of patients. But in many environments, they're never given a choice. In many environments, they're never even told that there are alternatives to colonoscopy, which turns out to be a really big barrier to moving people's screen. So let's talk in a little more detail about modern stool tests. WIAC tests. WIAC tests have actually been around for probably 40 years or more, maybe 50. And what many people don't appreciate is WIAC tests are the kinds of tests that were used to prove that colorectal screening is effective. There are 3 randomized controlled trials of colorectal cancer screening using WIAC-based tests, all of which demonstrated a decreased likelihood of dying from colorectal cancer. 3 randomized controlled trials. How many randomized controlled trials of colonoscopy screening do we have? 0. We have none. So when people talk about practicing evidence-based medicine and then promote colonoscopy as the only screening choice, that's actually contrary to the evidence. Now we have a lot of secondary evidence that indicates colonoscopy is effective. So again, I'm not questioning its efficacy, but I'm just saying based on the evidence, stool testing should be the only thing that we are recommending, or should be our primary approach. And as a matter of fact, the Canadian Task Force on Colorectal Cancer Screening a few months ago created quite a stir because they published new guidelines and said stool testing should be the primary approach to colorectal screening. And colonoscopy is not recommended for screening in Canada. That had to do in part with the fact that we have RCT data for stool testing and don't have any RCTs at this point for colonoscopy. But it also had to do with the fact that it's a cost-related issue. And you can screen many, many more people for the same amount of money using a stool test approach. So, in Canada, they're not like the US where, we act like money doesn't matter, even though it clearly does. And they took the approach that, no, colonoscopy is not indicated for screening. I think that's kind of a stretch because there is a lot of very good, but just not RCT evidence. But again, 3 randomized controlled trials showing that we can decrease deaths from colorectal cancer using old WIAC tests, using relatively primitive technology. One of these published just a couple of years ago a 30-year follow-up and showed that 30 years after being part of this trial, those patients were still almost 30% less likely to die of colorectal cancer than patients who were in control 30 years later. So it has a benefit and it has a lasting benefit. So now it is important to keep in mind that every WIAC test on the market requires collecting specimens from 3 separate boundary points. That WIAC tests are non-specific, and that is blood from any source will cause a positive WIAC test. A rare steak the night before you collect a stool specimen may cause a positive WIAC test. Certainly if you have esophagitis or an ulcer that is bleeding, you can get a positive WIAC test. There are a variety of different foods and medications that cause positive WIAC tests. And the list is very lengthy. You can have it can cause either a false positive or false negative from a lot of different foods and meds. And the key factor is, however, we've made some significant improvements in WIAC technology, and Hemoccult Sensa is a much, much more sensitive kind of WIAC test than Hemoccult 2 or than essentially all of the other generic WIAC tests on the market. And the difference is so significant. We're talking about a 60% sensitivity for cancer with Hemoccult Sensa compared to somewhere in the range of 20 to 25% for Hemoccult 2. That led the ACS to actually say that Hemocolt 2 and other generic forms of guaiac should not be used for colorectal screening. So if you are using a guaiac test in your practice, it should be Hemocolt sensitive. Otherwise, you're not doing high-quality stool testing. The Preventive Services Task Force doesn't say exactly that, but they say high-sensitivity guaiac. And Sensa is the only high-sensitivity guaiac that has performance data in the medical literature. So we basically say the same thing, they're just a little hesitant to actually use brand names. Now, fecal immunochemical tests also look for hidden blood, but they look for a different portion of the hemoglobin molecule. And because the portion of the molecule that they look for, the globin portion, is changed as it passes through the upper GI tract, it's changed by GI enzymes, that makes this test significantly more sensitive and specific. It is specific for human blood, so you will not get that rare state that I talked about will not cause a positive FIT. But it also is specific for bleeding from the lower GI tract. Because globin is changed as it goes through, if you have that esophagitis or ulcer and you're having a little bleeding, those stomach enzymes are going to change it so that by the time it passes out in the stool and you do the FIT, you will not get a positive FIT. So a positive fecal immunochemical test is highly correlated with blood occurring in the colon, in the lower portion of the GI tract. So subsequently, you have fewer false positives with FIT than you do with Hemocolt sensing. In addition, a number of the brands on the market require collecting only 1 or 2 specimens versus 3 specimens, although we'll talk about some of that as well. These are much more sensitive than all guaiac tests. They're more sensitive than Sensa, as a matter of fact, than most of the head-to-head studies. And they do cost more than guaiac tests, but a couple of things. One, there are some labs that will provide these kits to you at no cost, as long as you send the kit directly back to them for processing. So you, as the clinic or the clinician, don't get to bill, but you also don't incur any cost associated with it. And then there are there are a growing number of opportunities to basically cut deals with labs. And I was talking to someone from an FQHC sometime last week who said that they've been able to work out a deal with one of the labs for $5 fit kits using a high quality fit kit. So the labs are really very actively trying to promote the use of fit. And as a matter of fact, LabCorp a couple of years ago just did away entirely with doing any guaiac-based testing and moved entirely to fit. So there are ways to get around that. In addition, if you are having to pay for the kits, you can bill at a much higher rate than you can for Sensa. The Medicare billing for guaiac tests, I believe, is somewhere, or Medicare reimbursement somewhere around $8. Reimbursement for FITs is about $23 to $25 or $6. That means, though, you've got to get a good return rate, and we'll be talking in some detail about how to boost your return rate, so because you can only bill for those kits that are actually returned in the process. With regard to the accuracy of FIT, looking at colorectal cancer, this meta-analysis published a couple of years ago looked at studies of fecal immunochemical tests that were supported by endoscopy findings, so either colonoscopy or in a couple of cases flexible sigmoidoscopy. So they know what was actually in the colon. And what they found looking at a number of different brands, some of which aren't available in the US and a couple of which are older brands and simply not available anywhere anymore. But in general, looking at those high quality studies, they found a sensitivity for cancer of between 75 and 80%. So cancer sensitivity of 75 to 80% for high quality FITs. And their specificity was over 90%. Remember I mentioned earlier, you're going to get many fewer false positives with FIT. So these tests, if you're using a high quality version, have really good performance. The U.S. Preventive Services Task Force, in their draft guideline update, they also published their evidence review and a modeling study that they did to try to determine the effectiveness of different approaches to colorectal screening. And looking just at this bottom set of bars here, looking at the colorectal cancer deaths averted per 1,000 individuals screened. This model said that colonoscopy once every 10 years would avert 24 colorectal cancer deaths for every 1,000 individual screened. 24 deaths averted for 1,000 screens. That's really good performance for any kind of screening. But then they also looked at FIT every year or GWAG, high sensitivity GWAG testing every year, and determined that it would avert 22 deaths for every 1,000 individuals screened. So, is colonoscopy better? But it's marginally better. We're not talking about a huge difference. So these tests, if done well, can be very, very effective. But they have to be done well. So we're going to talk about quality issues. Yes?
I have one more question, I'm sorry. Some of our labs in North Dakota and South Dakota, in our IHS facilities, are using now what they call IFOBs. Can you talk about those? And
IFOB is just a different way of saying FIT.
It's a fit?
Chemical fecal equivalent.
Because then they don't have to send that to the lab.
Well,
Or to an off-site lab, they can test it at their lab.
I'll talk about that a
Okay.
little later. So as I mentioned, there are a lot of different brands.
I was confused.
Yeah. Well, IFOBs and FIT are the same general category, but there are different brands. So at any rate, high-quality stool testing program compared with a high-quality colonoscopy. High-quality colonoscopy. Does this microphone make a difference? Can you hear me without it?
It's louder with it.
It's louder with it. Okay.
Yeah.
We get tired of holding it.
We'll see if we can do something.
At any rate, so is colonoscopy, it will save a few more lives, but not a lot. So you get a good bang for your buck, so to speak, with stool testing. Now, stool testing also has a number of other advantages over colonoscopy. One, it's strikingly less expensive. Colonoscopy, if you have a patient who is uninsured or whose insurance, for whatever reason, doesn't cover colonoscopy, you're talking about, at best, out-of-pocket cost of $1,500, and in many cases, $5,000 or $6,000 for colonoscopy. Stool tests are, usually in the $15 to $20 to $30 range. So very, very big difference. So even for uninsured, many uninsured patients can actually afford to have stool testing. That bowel prep that I talked about is being so much fun that you don't have to deal with as part of stool testing. It's done in privacy at home, which actually for a lot of patients is a big deal. There's no need to take that time off work. You don't have to lose a day's pay. You don't have to tie someone else up. It's non-invasive. There is no risk from stool testing, at least none that I've heard. I've given this talk probably 100 times, and I always ask, anybody ever had a patient injured collecting a stool specimen? Okay, still batting 100. And very importantly, particularly in environments where either colonoscopy is difficult to get to, like some of the geographies here, or where colonoscopy is not widely available. I know for a lot of the QHCs and a lot of the native serving environments, that getting a colonoscopy for your patients can be a challenge. There may be only so many available to you or in your area. FIT, or stool testing overall, significantly limits the need for colonoscopy. If you're screening everybody with colonoscopy, that means that all of these 1,000 patients have to be referred. Some aren't going to show up, but a lot of them are going to need to have a colonoscopy. And out of those 1,000 patients, you're going to find one cancer in about 1 out of every 400 to 1,000 colonoscopies. So you're going to find very few cancers and do a lot of colonoscopies to find those cancers. Now, on the other hand, if you're doing stool testing, you're going to test a lot of patients. Matter of fact, you can test double the number of patients. And you're going to find one cancer in many, many more because you're only doing colonoscopies in those individuals who had a positive stool test. So you're going to end up finding one cancer in about 1 out of every 20 colonoscopies. So you end up finding a lot more cancers doing many fewer colonoscopies. So it helps extend a very limited resource. Now, just as with colonoscopy, there are a number of very important quality issues that you have to keep in mind. If you're going to do a quality stool testing program, number one, only average risk. So you have to make sure you're differentiating risk. You only use high sensitivity stool tests, so either an FIT or IFOB, or Hemocolt sensor. That's the only YAP that has good performance data. There are throw in the bowl toilet bowl tests. Are you all familiar? Anybody have patients who use those or seen these ads? Yes, they're these YAC impregnated tissues that you throw in the toilet bowl, and then the patient has a bowel movement, and if the tissue turns blue, then they think they got cancer. But if it stays orange or pink or whatever, then they're fine. Those tests are, number one, they're based on Hemocolt or Hemocolt 2 level technology, so very poor sensitivity. Number two, there are no studies that have looked at them and demonstrated their ability to find polyps or cancer. So they are totally unproven and are not recommended in the guidelines of any organization. Stool tests have to be repeated every year. As I said earlier, their sensitivity for cancer is somewhere in the 70 to 75% range at best. That means that they're going to miss up to a quarter of cancers that are there at the time of testing, and they're going to miss many more polyps. But if you're doing the testing every year, then there's a good chance you'll either find the polyp before it transforms to cancer, or you'll find that cancer in early stages, which is why they can save so many lives. So it has to be repeated every year. And every positive test has to be followed with colonoscopy. To assume, oh, well, you didn't follow the diet right, or that must have been your hemorrhoids, let's just ignore it and come back next year. Every positive stool test is cancer until proven otherwise. Every positive stool test must be followed with colonoscopy. And you and the patient should understand that. The patient should understand that going into the process. So that if they're deciding between colonoscopy and stool testing, you need to let them know, if this is positive, you have to have a colonoscopy. So this is not something you do just to avoid ever having to deal with colonoscopy. Yes, sir.
So you're hypersensitive about screening your patients. You do your colonoscopy and you step up and do fit testing on an annual basis. Colonoscopy is negative. 3 years from now, your fit card comes back positive. At what point do you recommend a repeat colonoscopy, understanding that 10% can be abnormal?
If you are doing that, you've put yourself in the box of having to repeat that colonoscopy. Because as I said, every positive fit is cancer until proven otherwise. But basically, you shouldn't do that. Doing stool testing in between normal colonoscopies is not recommended by any organization. That's because the likelihood of a false positive is much higher than the likelihood of a true positive. And there have been a number of studies that have looked at this, none out to that 10-year window, but doing stool testing every year up to 5 or 7 years after a normal colonoscopy. You'll find a few cancers, because there are cancers missed by colonoscopy, but you will have many, many more patients who have a false positive, and you're sending them for extra colonoscopies with really no benefit to them. So repeating stool testing between normal colonoscopies is not worthwhile. And if a patient has that normal colonoscopy I spoke about earlier, and then they develop new symptoms, stool testing isn't going to give you an answer. If they're having new symptoms that you're concerned enough about, then you need to just go ahead and send them to endoscopy, because whether that stool test is positive or negative, if they're still having symptoms, we know that that stool test is potentially going to miss 25 or 30% of abnormalities. So, but stool testing between normal colonoscopies is not recommended. And it's, again, more likely to put you in a position of sending people for extra colonoscopies that are probably not going to benefit. And then finally, this is a real pet peeve of mine. All right, everybody, pay attention. I know I've been talking a long time. Some of you are drifting off, thinking about the drive home or whatever. This is the key point of this entire talk. If you remember nothing else, please remember what I'm about to tell you. And go home and tell your friends and colleagues. The digital rectal exam is not a screening test for colorectal cancer. Everybody say it with me. The digital rectal exam is not a screening test for colorectal cancer. Many, many clinicians that I've come across, and those that are reported in the medical literature, say, well, we give patients these kits, they don't bring them back, I got them in the office, I'm going to do a rectal exam, I'm going to smear it on my sensor card, or I'm going to stir it around in my little developer, and if that is negative, boom, they've been screened for colorectal cancer. I don't need to worry about it. They have not been screened. Unfortunately, no one has looked at this issue with fit testing, so we don't have clear evidence that it is ineffective, but there are no studies showing that that's an effective approach. For diet testing, we know it doesn't work. There have been a number of smaller studies, but one really good large study that looked at this. 2,100 patients, all of whom were due colorectal screening, scheduled for screening colonoscopy. Before their colonoscopy, they had a digital rectal exam. And then they went to colonoscopy, and the DRE findings were compared with the colonoscopy findings. In those 2,100 patients, they found 21 cancers. Of those 21 cancers, 2 patients had a positive digital rectal exam sample. 19 or 21 people who had cancer, you knew they had cancer at the time that test was done. 19 of 21 had a normal DRE, no blood on their guaiac test, and were told, or would have been told, come on, fine, come back next year with cancer. Any test that misses 19 of 21 cancers is not a reasonable screening test. Yet, the last study that looked at this found that about 24% of primary care clinicians often or frequently or sometimes always use the digital rectal exam as the colorectal screening test. One more time, the digital rectal exam is not